respected President IAP Kerala, Jayaraman sir, Past President Dr. Narayan sir, Secretary Johnny Sebastian sir, and Past Secretary Dr. Balaji sir, Joshi sir, my senior colleagues and my രണ്ടാഴ്ച മുമ്പ് ഒരു TPO വിളിച്ചൊരു മീറ്റിംഗിൽ പങ്കെടുക്കുകയുണ്ടായി. അന്ന് പിന്നെ ഈ ഡെപ്യൂട്ടി കൺസൾട്ടന്റ് രാജേഷ് സാർ ഒരു കണക്ക് പറയണ്ടായി. അതായത് നമ്മുടെ മലപ്പുറം ജില്ലയിൽ TB കേസുകളിൽ 16% പീഡിയാട്രിക് TB ആണ് അവരുടെ കണക്കിൽ വന്നിട്ടുള്ളത്. അത് മറ്റ് ജില്ലാ അപേക്ഷിച്ച് വളരെ കൂടുതലാണ്. ഒരു 5 to 6% മാത്രമാണ് മറ്റ് ജില്ലകളൊക്കെ ഉള്ളത്. നമ്മളുടെ മാത്രം കുറച്ച് കൂടുതലായിട്ട് കാണുന്നത്. അതിൽ തന്നെ സ്റ്റുഡൻറ് കൺഫേംഡ് TB വളരെ കുറവാണ്. അപ്പോൾ അത് ഡയഗ്നോസിൽ കുറച്ച് ഓവർ ഡയഗ്നോസിസ് വരുന്നുണ്ടാവും എന്നുള്ളൊരു ഇംപ്രഷൻ കിട്ടുന്നുണ്ട്. അതുകൊണ്ട് കൂടുതൽ ട്രെയിനിങ് നമ്മുടെ പീഡിയാട്രിഷ്യന്മാർ ആവശ്യമുള്ളൊരു ഇത് വന്നിട്ടുണ്ടായിരുന്നു. അതിന്റെ അടിസ്ഥാനത്തിൽ ഞാൻ ജോലിക്കാരുമായി ഡിസ്കസ് ചെയ്തിട്ടുള്ളതാണ്.
Sadiq, you are not audible properly. Clear.
ഹലോ.
Yeah.
അങ്ങനെ ആ ഒരു മീറ്റിംഗിൽ അങ്ങനെ ഒരു വിഷയം വന്നുകൊണ്ടാണ് പിന്നെ പെട്ടെന്ന് കഴിഞ്ഞ വർഷം കോഴിക്കോട് പ്രോഗ്രാം തന്നെയാണ് നമുക്ക് മലപ്പുറം ജില്ലയിൽ ഒരു താല്പര്യം ഉണ്ടായിരുന്നത്. ഇതിന്റെ വിഷയത്തിലാണ് നമ്മൾ പ്രോഗ്രാം വെച്ചിട്ടുള്ളത്. അതുപോലെ തന്നെ ഇതോടനുബന്ധിച്ച് വേറൊരു കാര്യം പറയാനുള്ളത്, ഇന്ന് DMOയുടെ ഒരു മീറ്റിംഗ് ഉണ്ടായിരുന്നു. അതായത് വോട്ടിംഗ് ഇമ്മ്യൂണൈസേഷൻ കുറഞ്ഞു വന്നിട്ടുണ്ട്. ഈ കോവിഡ് കാരണം വോട്ടിംഗ് ഇമ്മ്യൂണൈസേഷൻ കുറഞ്ഞു വന്നിട്ടുണ്ട്. അതുകൊണ്ട് മിഷൻ ഇന്റർവെൻസ് ഒന്നുകൂടി കൊണ്ടുവരുന്നുണ്ട്. ഫെബ്രുവരി 22 മുതൽ മാർച്ച് 22 വരെ മിഷൻ ഇന്റൻസീവ് മിഷൻ.
Hello, excuse me, Sadiq, one thing. Hello. ഒന്നുമില്ല, എനിക്ക് തോന്നുന്നത് ആ ഇയർഫോൺ ഒഴിവാക്കിയാൽ ശരിയാവും തോന്നുന്നു. ദർ ഇസ് സം പ്രോബ്ലം വിത്ത് ഇയർഫോൺ. അല്ല, അത് എന്റെ കുഴപ്പം മാത്രമാണോ?
കുറച്ച് ഒച്ചത്തിൽ പറഞ്ഞാൽ മതി.
ഇതിന്റെ പ്രോബ്ലം എന്താണെന്നറിയാം. ഇപ്പൊ എടുത്തു വെച്ചപ്പോഴാണ്. ഇപ്പൊ കേൾക്കുന്നുണ്ടോ? ഹലോ,
കേൾക്കുന്നുണ്ട്.
ഓക്കെ. അപ്പം മിഷൻ ഇന്റർവെൻസ് മാർച്ച് 22 മുതൽ ഫെബ്രുവരി 22 മുതൽ മാർച്ച് 22 വരെ 5 ജില്ലകളിൽ പ്ലാൻ ചെയ്തിട്ടുണ്ട്. അതിലൊരു ജില്ല നമ്മുടെ മലപ്പുറം ജില്ലയാണ്. അപ്പൊ അതിനുവേണ്ടി എല്ലാ വിദ്യാർത്ഥിമാരും സഹകരിക്കണമെന്ന് അപേക്ഷിച്ചിട്ടുണ്ട്. ആ അഭ്യർത്ഥന ഞാൻ എല്ലാവരെയും അറിയിക്കുകയാണ്. ഈ മീറ്റിംഗിലേക്ക് ഞാൻ IAP പ്രസിഡന്റ്, സ്റ്റേറ്റ് പ്രസിഡന്റ് IAP ജയരാമൻ സാറിനെ ആദ്യമായി സ്വാഗതം ചെയ്യാണ്. അതുപോലെ തന്നെ പാസ്റ്റ് പ്രസിഡന്റ് നാരായണ സാറിനെയും, അതുപോലെ തന്നെ ജോണി സെബാസ്റ്റ്യൻ, പാസ്റ്റ് സെക്രട്ടറി ബാലചന്ദ്രൻ സാർ, ഇവരെല്ലാം ഞാൻ സ്വാഗതം ചെയ്യാണ്. അതുപോലെ തന്നെ നമ്മുടെ ക്ഷണം സ്വീകരിച്ച് WHO കൺസൾട്ടന്റ് TB ബന്ധപ്പെട്ടുള്ള ഡോക്ടർ രാജേഷ് സാർ ഇവിടെ എത്തിയിട്ടുണ്ട്. അദ്ദേഹത്തെ ഞാൻ ഈ പരിപാടിയിലേക്ക് ആദ്യമായി സ്വാഗതം ചെയ്യുന്നു. അതുപോലെ തന്നെ DTO, നമ്മുടെ മലപ്പുറം ജില്ലയിലെ ഡിസ്ട്രിക്ട് TB ഓഫീസർ, അദ്ദേഹം ഡോക്ടർ അരുൺ ഇവിടെ എത്തിയിട്ടുണ്ട്. അദ്ദേഹത്തെ ഞാൻ ഇതിലേക്ക് ആദ്യമായി സ്വാഗതം ചെയ്യുന്നു. ഡോക്ടർ TP അഷ്റഫ് പങ്കെടുക്കാവുന്ന ഏറ്റിരുന്നെങ്കിലും പെട്ടെന്നുണ്ടായ ചില കാരണങ്ങൾ കാരണം പങ്കെടുക്കാൻ പറ്റുന്നില്ല. അതുപോലെ തന്നെ നമ്മുടെ മോഡറേറ്ററായിട്ട് നമ്മുടെ ഡോക്ടർ ഫൈസൽ MES മെഡിക്കൽ കോളേജ് അദ്ദേഹമാണ് മോഡറേറ്റർ ആയിട്ടുള്ളത്. അതുപോലെ തന്നെ പ്രസന്റ് ചെയ്യുന്ന ഡോക്ടർ ജോഷി സർ, ഡോക്ടർ ഷിബു, ഡോക്ടർ ദീപു ആൻഡ് ഡോക്ടർ ജുമാൻ, അവരെല്ലാവരെയും ഞാൻ ഈ പരിപാടിയിലേക്ക് ആദ്യമായി സ്വാഗതം ചെയ്യുന്നു. അതുപോലെ തന്നെ ഇതിൽ ജോയിൻ ചെയ്തിട്ടുള്ള എല്ലാ IAP മെമ്പേഴ്സിനെയും ഇതിലേക്ക് ആദ്യമായി സ്വാഗതം ചെയ്തുകൊണ്ട് ഈ പ്രോഗ്രാം ഉദ്ഘാടനം ചെയ്യുന്നതിന് വേണ്ടി നമ്മുടെ IAP കേരള പ്രസിഡന്റ് ഡോക്ടർ ജയരാമൻ സാറിനെ ക്ഷണിച്ചുകൊണ്ട് ജയരാമൻ സാർ.
Good evening, everybody. Hope I am audible.
Yes.
Respected President Dr. Akbar Sadiq, Secretary Dr. Juman, Past President of IAP Kerala Dr. Narayanan, Past President Dr. Joshi, Dr. Johnny Sebastian, Secretary IAP Kerala, Dr. Balachandran, Chairman of the TB Free Air Action Plan of IAP Kerala. Faculties of the day, Dr. Faisal, Dr. Dibu, Dr. Shibu, and Dr. Juman. and seniors in the profession, Dr. Venusar, Dr. Shivaraman, Dr. Nandakumar, and many others. I'm very happy to participate in this program. Actually, when we planned the action plan for this year, and Dr. Narayanan was very particular that we should include TB-free air program this year also. And actually, there was some doubt why we should, what is there to continue this year. And it was so apt. Dr. Joshi came with the suggestion that even though we have given training to so many pediatricians, there are so many people left in IAP Kerala who have not undergone this training on programmatic management. And IAP Malappuram is starting with once again the program for those who have not attended the program last year. And Dr. Balachandar has drafted a wonderful follow-up plan for this TB-free air plan, which was there last year. So let us start with the program of last year itself, that is the programmatic management of the TB. And I don't want to go into details of the program because the experts should talk about it. And anyhow, I am very happy to inaugurate this session as part of this year's presidential action plan. And I thank IAP Malappuram for arranging this session. And also to all those who are attending this program. And I wish the very best for this program. Thank you so much. And also I welcome Dr. Jakesh and Arun Jacob from the TB consultants for this program. Thank you so much.
Now I invite Dr. Rajesh to say a few words.
So very good evening, respected IAP President Jayaraman sir, Secretary Johnny Sebastian sir, Dr. Narayanan sir, Dr. Balachandar, Dr. Akbar Sadiq, and all respected dignitaries. I'm not taking much time, but I would take this opportunity to express sincere appreciations to the Indian Academy of Pediatrics and the leadership for raising the voice for children. The children cannot talk, so the doctors of children, the pediatricians, is raising the voice for children. And this IAP's, this initiative has been well acknowledged nationally and internationally. And many international organizations and experts are watching the activities that IAP is doing for TB elimination in Kerala. So IAP Kerala State Branch is doing this activity not only for Kerala, but for many other states and countries. This is an update from my side. I know that many of the international TB community is closely watching and discussing this activity. So once again, thank you so much for the sincere leadership and support from the IAP. And we could see that Kerala Health Webinar Conference is happening now. Government is conducting series of webinars, and we could see that IAP's logo is there in that webinar as a partner also, as a formal partner. We couldn't find any other organizations as such. So with this, I conclude my speech. I will be available. So thank you so much. And once again, hearty congratulations.
Thank you, sir. Now I invite the TB officer, Dr. Arun.
Hi, good evening to all. Respected IAP President Dr. Jayaraman, Secretary Dr. Johnny Sebastian, Chairperson Dr. Chandrasekhar, moderators, IAP of Malappuram office bearers Dr. Akbar Sadiq and Dr. Juman, and other senior faculties and other IAP members. See, for last more than 50 years, we have been dealing with TB. And I think by 2030, we are coming to a TB elimination as per the target set by SDG. So in line with the SDG, the Government of India has formulated a national strategic plan, that is 2017 to 2025, that we can come to an elimination of TB by 2025. So now all the activities are being lined in with the elimination activities. So for these things, we have 4 main strategies. That is mentioned in the NSP document, that is detect, treat, prevent, and build. That is, we need to detect the undiagnosed cases of TB, then treat as per the guidelines, then then comes the prevent strategy in which the LTBI management comes in. That is, we need to prevent the activation of latent TB to active cases of TB, so that we can have a check on the number of rising TB cases. So LTBI should be our main component of TB elimination. So we all should work for it. And as when we come through the activities of LTBI system in Malappuram, we are now equipped with 5 IGRA testing labs. That is one in DH District Hospital Tirur, Taluk Hospital Tirurangadi, Malappuram Public Health Lab, Government Medical College Lab Manjeri, and District Hospital Nilambur Lab. So all our activities are now well going on, like the Akshay Kerala campaign. Also, we are conducting, or the Government of India in help with ICMR and IAPSM. Now a survey is going on in Malappuram regarding the TB-free certification claim. And I thank IAP Malappuram for all the TB-related activities so far, and I wish today's CME a success with all our eminent faculties. Thank you.
Thank you, sir. Now I invite past Kerala IAP Kerala President Dr. Narayanan sir to say a few words.
Yeah, good evening to you all. Dr. Akbar Sadiq, Dr. TP Jairam, Dr. Arun Jacob, Dr. Rakesh, senior pediatricians, and my dear friends in IAP. Just on the 1st of November, the Kerala Piravi Day, that the Honorable Governor inaugurated this program. That was the action plan. TB-free air for every child in Kerala. It's only I think it is only since only 3 months have passed after that. And during this time, we had 3 zonal training programs where nearly 1,000 pediatricians were trained. And I'm very happy that Malappuram district has taken up this program in this February month. And Dr. Balayender, who is the convener for the chairman for the program, and he has already chalked out a lot of programs related to LTB management. And we can be proud that IAP Kerala is behind the government, and it is the only state in India which has launched a programmatic management for latent TB infection in children. It's the only state in the country. And I should thank the support of Dr. Rakesh from WHO side and the state TV cell for this program. And definitely we will be having at least one program a month, so that we get brushed up with the latest what is happening in latent TB management. I wish this program all success. Again, congratulating Malappuram branch for organizing this program. Thank you.
Thank you, sir. Now I invite Dr. Johnny Sebastian, IAP Kerala Secretary.
Respected President, Dr. Akbar Sadiq, IAP Kerala President Dr. TP Jayaraman sir, Dr. Joshi sir, Dr. Narayanan sir, Dr. Rakesh sir, Dr. Arun sir, Dr. Balachandra sir, Dr. Juman, then the moderators and speakers of the day, senior colleagues, and my dear friends. At the outset, let me congratulate IAP Malappuram team for arranging this training session on latent tuberculosis diagnosis and management. As we all know, there is a lot of confusion among the general pediatricians regarding this particular topic. I wish this CME training all success. Jai Hind, Jai IAP. Thank you.
Thank you, sir. Now I invite Dr. Faisal, Professor of Pediatrics, MES Research in the to moderate. Yes, sir.
Sadiq, I couldn't hear you. What did you say? Just to moderate the session or something else?
Yeah.
Sadiq?
Take on.
Okay. Okay, good evening. Good evening, everyone. Respected senior person, President IAP, Dr. Jayaraman sir, past President Dr. Narayan sir, Secretary Dr. Johnny Sebastian, WHO Consultant Dr. Ragesh, District TB Officer Dr. Arun, and my dear senior colleagues and friends. So I'm very happy to be here. And first of all, I would like to place on record my sincere gratitude for inviting me to chair this session. And we have another moderator, Dr. Ashraf sir. He's busy with another meeting, which is an emergency meeting. So hopefully he'll be coming during this meeting. And that said, today our discussion is about latent tuberculosis infection management, LTBI management. Now, LTBI is defined as a persistent inflammation going on due to various. So it's very important to identify this because WHO end strategy for tuberculosis, they consider this management of LTBI as an important strategy for preventing TB, and we are aiming to prevent TB by 2025 in India. So it's an important step among other things like active case discussion and management, BCG vaccination. So another important thing we need to understand that TB is now a notifiable disease. So not notifying TB, we are liable for action, So that's an important thing. So we should notify and to the concerned authority, and then only we can treat LTBI. So that's one important message, and there are many things which will be coming. We will be discussing when the various topics about this LTBI is going on. So with that, I conclude, and I invite Dr. Joshi sir to talk about. First one is LTBI, right? What is the first topic, sir? Joshi sir?
Shibu, please share the slides. Due to some technical problems, I cannot share it.
Okay, Shibu, please share the.
Okay, same as.
പേഷ്യന്റ് നിങ്ങളെ കാണാൻ വന്നിട്ടുണ്ട് കേട്ടോ. അപ്പൊ നേരത്തെ വിളിച്ചവരാണോ ഇത് വേറെ ഒന്നും.
Everyone, please make sure that your audio is muted. Please mute your audios, otherwise it will be a great disturbance for this.
Hello, Shibu. അതെ, അത് ഹോസ്റ്റിനോട് പറയണം. ഞാനല്ല ഇപ്പൊ ഹോസ്റ്റ്. ഇപ്പൊ ഹോസ്റ്റ് ഇറ്റിയോ ആണ്. Dr. Arun, please enable share content.
സാറേ ഒന്ന് ഷെയർ സ്ക്രീൻ ഒന്ന് എനേബിൾ ചെയ്യോ എന്റെ?
ചെയ്യാം. കിട്ടിയില്ലല്ലേ സർ? ഒരു സെക്കൻഡ്.
Joshi sir, you have that slides in your WhatsApp, right? സാറിന്റെ വാട്സാപ്പിൽ ഇല്ലത്?
ഉണ്ട്. അത് ഷിബുവിനോട് ഞാനിപ്പോ കുറച്ച് നോക്കുമ്പോ എനിക്ക് കണ്ടൻസ് ഷെയർ ചെയ്യാൻ പറ്റാതെ വന്നപ്പോ ഞാൻ ഷിബുവിനോട് വിളിച്ച് പറഞ്ഞിരുന്നു. ഇപ്പൊ അത് എനേബിൾ ചെയ്തില്ലേ?
ഇല്ല, എനേബിൾ ആയിട്ടില്ല.
ആയിട്ടില്ലേ?
ഇല്ല.
രാകേഷ് സാറ്, രാകേഷ് ആരാണ്? ഡോക്ടർ അരുൺ.
ഓക്കെ.
അതെ,
വന്നു.
ഇപ്പൊ ശരിയാണ്.
From session 1, 2, 3 I am doing.
സാറേ കാണുന്നില്ലേ? സ്ക്രീൻ കാണുന്നില്ലേ?
ഇല്ല, വരുന്നില്ല. സ്ക്രീൻ കാണുന്നുണ്ട്. അതിൽ ആ PMLTBI TOT അത് മാത്രമേ കാണുന്നുള്ളൂ. അതിന്റെ സ്ലൈഡായിട്ട് വരുന്നില്ല. അന്ന് ഞാൻ ഷിബുവിന് അയച്ചു തന്നില്ലേ? അതല്ലേ?
അതെ, ഇതല്ലേ? അത് ഞാൻ മാറുന്നുണ്ടല്ലോ ഇവിടെ.
അത് ഷിബു എന്താ ചെയ്യേണ്ടതെന്ന് അറിയോ? ഷിബു അത് ആദ്യം ഡെസ്ക്ടോപ്പില് എടുത്തു വെച്ചിട്ട് പിന്നെ അവിടുന്ന് എടുക്കണം.
അതെ, ഡെസ്ക്ടോപ്പിലാണ്.
പക്ഷെ ഇവിടെ കാണുന്നില്ല, നമ്മുടെ സ്ക്രീനിൽ കാണുന്നില്ല.
ആണോ?
അത് എനിക്ക് തോന്നുന്നത്
കാണുന്നുണ്ട്, പക്ഷെ ഇപ്പോഴത്തെ അത് ഡെസ്ക്ടോപ്പിൽ എടുത്തു വെച്ചത് കാണുന്നില്ല.
അതായത് നീ അത് ഓപ്പൺ ചെയ്തിട്ട്, അതെ, ഒന്നുകൂടി ക്ലിക്ക് ചെയ്ത്
ഓപ്പൺ ചെയ്താൽ
അതെ.
ഇപ്പൊ വരുന്നുണ്ട്. ഇപ്പൊ വരുന്നുണ്ട്, പക്ഷെ അത് ആ സ്ലൈഡ് ഷോ
ക്ലിക്ക് ചെയ്യേ.
സ്ലൈഡ് ഷോ ആണ്.
അല്ല, അതല്ല, അത് ഫുൾ സ്ക്രീൻ ആക്കാനേ. ഇത് മതി സാറേ. I think we can start.
Good evening, everybody. Moderator Dr. Faisal, President IAP Kerala Dr. Jayaraman, President IAP Malappuram Dr. Akbar Sadiq, distinguished guests, and my dear friends. Now we are going to deal with programmatic management of latent TB infection among children and adolescents in Kerala. We are dealing with the implementation plan. Next slide, please. Shibu, please change the slide.
ഞാൻ ചേഞ്ച് ചെയ്തിട്ടുണ്ടല്ലോ, വന്നില്ല.
ഇല്ല,
Yeah.
Libu,
ഇപ്പോഴോ?
ഇപ്പൊ അത് ഇപ്പൊ വന്നിട്ടുണ്ട്. Kerala is witnessing a rise in proportion of aged in the total population with declining growth rates. In last decade in India, the population growth rate was 17.64%, whereas in Kerala it was only 4.83%. Except one district, all districts in Kerala have a declining child population. Our infant mortality rate of 7 per 1,000 live births is at par with that of developed nations. Widespread education and high literacy rates are present in Kerala. Our literacy rate in males is 96.11% and in females it is 92.07%. This high female literacy rate it is very useful for the implementation of all our programs. We have a systematically organized primary healthcare system. All primary health centers are manned by modern medical practitioners in Kerala. Kerala is one of the states with lowest HIV transmission and has nearly eliminated mother-to-child HIV transmission. This slide I shall discuss later. Next slide, please. Pediatric TB in Kerala. Average annual decline in pediatric TB notification is 7.5% from 2009 to 2019. The age-specific TB notification among children 14 years and less is around 1 per 1 lakh population. Pediatric anti-TB drug sale had a steeper decline. From pharmaceutical companies, we have noted that 90% of reduction in pediatric drug formulations for TB is noted from 2006 to 2019. Less than 1% of presumptive pediatric TB samples tested in CBNAT turned out to be positive in the states. A study done in 2006 showed that estimated annual risk of TB infection, that is, it is 0.4 only in our states, which is only 1/5 of that of the national estimates, that is 1.5. Next slide. Kerala TB elimination mission. Our aims are to achieve sustainable development goals related to TB. Our aim is to is elimination of TB by the year 2025. If the mission is envisaged as a people's movement against TB. Strategy document, which is the customized version of National Strategic Plan India, has enumerated 48 activities. In Kerala, we have customized it according to our needs. Next slide. The theme is My TB Free Panchayats. 561 panchayats had 0 under 5 TB in 2019. 688 panchayats had 0 lost to follow-up in 2019. And 709 panchayats had 0 drug-resistant TB in 2019. Next slide. In Kerala, the standards of TB care are very good. Proportion of TB patients with multi-drug resistant tuberculosis is comparatively lower in Kerala. Among new TB patients, rifampicin resistance is seen in less than 1% only, and among previously treated, it is around 3.5%. The reported recurrence is less than 5%. Long-term follow-up confirms low recurrence. In Kerala, private sector follows a reasonable standards of TB care, which is enhanced with system for TB elimination in private sector, that is STEPS steps. Next slide. Akshaya Kerala. The TB elimination, this mission in Kerala is called Akshaya Kerala. This phase 3 is called Akshaya Kerala. We are aiming to give TB preventive therapy to all children less than 15 years, starting from November 2020. Due to this COVID situations and all, some delay is natural. Detecting and treating latent TB infection among children will help to achieve the goal of childhood TB free Kerala. It will prevent 1,000 children getting TB every year in the states. And we are planning TB services to be at the doorsteps of the people. Efforts for reorienting field services have started. It was supposed to start from November 2020. The details we can have from our district TB officer later. TB services become more people-centric with minimal inconveniences to the people. We are planning to upfront molecular tests for TB diagnosis. This CBNAT test will come. It was planned to start from December 1st, 2020 onwards. The processes are going on for that. That is what I have understood. Early and accurate detection of all TB cases, including detection of drug resistance at baseline, is our aim. Next slide. TB-free air for every child in Kerala. This is the action plan of IAP president last year. Dr. Narayanan had included this in his 2020 action plan. Protecting child rights is the theme of IAP Kerala. It was the theme of IAP Kerala chapter last year. And TB-free air is the right of every child. IAP is raising the voice for children. This year also we are continuing this program. Next slide. Estimated total cases given the current trend. This is the current trend. In 2013, there were more than 40,000, around 45,000 cases of TB in India, and now in 2020, end of 2020, it became 25,000. If it goes on like that, it will be around 10,000 by 2025. But next slide. No. Previous slide. This slide. But due to the introduction of this program, this PM LTBI program, we are planning to eliminate TB in 2025, and also we want to eliminate deaths due to TB also in 2020. Next slide. TB preventive therapy. Prevention of active TB disease by treatment of LTBI is a critical component of WHO and TB strategy. Draft National Plan for PMLTBI, that is programmatic management of latent tuberculosis infection, developed by National Technical Work Group, is ready. Kerala State has locally customized the national plan. I have told you, according to our conditions, we have made some changes. Next slide. What are the prerequisites to roll out PMLTBI services? One is training of all pediatricians, program management staff, treatment supporters, etc. Then laboratory assessment, training for IGRA, specimen collection and transportation system and mapping of laboratories. The logistics which are needed are drugs, test kits, recording and reporting, setup of district pediatric TB committees. These are the prerequisites. LTBI basics and eligibility criteria. Now we are going to the eligibility criteria and LTBI basics. Next slide. From a source case, exposure of contacts occurs. From those who have been exposed, 30% have infection and 70% have no infection and no disease. Out of this 30% infection, the risk of developing disease is only 5 to 10%. And out of that 5 to 10%, more than 50% will occur in infancy and 25% in 1 to 5 years age group. These children who are getting the primary disease, the infection can be smear positive or smear negative. Smear positive is infectious. Smear negative also can be infectious. And the third type is extrapulmonary disease, which is non-infectious. The occurrence of the disease mainly depends on the host immunity. It also depends on the mycobacterial virulence. Those 90 to 95% cases who are infected will have persistent latent infection. And from this 90 to 95% of cases, late reactivation can occur and disease can occur. Next slide. Latent TB infection, why we need to treat. Latent tuberculosis infection is defined as a state of persistent immune response to stimulation by Mycobacterium tuberculosis antigens with no evidence of clinically manifest active TB. From the pool of infected but asymptomatic persons, most cases of tuberculosis will arise. On average, 5 to 10% of those infected will develop active TB, I have already stated, over the course of their lives, usually within the first 5 years after initial infection. The risk for active TB disease after infection depends on several factors, the most important being immunological status. The risk of developing TB disease after TB preventive therapy decreases 90% from 11.1% for those not taking LTBI treatment to 1.2% for those who have taken the treatments. Effective implementation of TB preventive therapy alone would result in decline in annual TB incidence of 12%, independent of other background interventions. Principle of PMLTBI in Kerala. It's a cascade of care approach which we have adopted. Series of things we have to do. Cascade of care approach shall be followed while implementing programmatic management of LTBI among children and adolescents in Kerala. It is important that all children at risk of developing TB are systematically reached out, screened. These are the various stages. TB disease ruled out and provided continuum of care for LTBI management. Kerala, with a lower incidence of pediatric TB and LTBI, it is suggested to have a test and treat approach for management of LTBI. I have told you that according to the existing conditions in Kerala, we have made some changes. In other states, it may not be like this. Next slide. Now let us see who is a household contact. A person who shared the same enclosed living space as the index patient for one or more nights or for frequent or extended daytime periods during the 3 months before the start of current treatment is a household contact. Next slide. Who all are eligible for LTBI treatments? 1. Children less than 5 years who are household contacts of microbiologically confirmed pulmonary TB may continue to be given TB preventive therapy after ruling out active TB. This is very important. For giving preventive therapy, we have to rule out active TB according to the current national guidelines. 2. A child born to mother who was diagnosed to have TB in pregnancy should receive TB preventive therapy provided congenital TB has been ruled out. If congenital TB is not ruled out, if it is diagnosed to have, if the child has developed congenital TB, then we have to give the full treatments. Next slide. 3. Children and adolescents 5 to 15 years who are household contacts of microbiologically confirmed pulmonary TB should be systematically tested for LTBI. If found to have latent TB infection, they shall be offered treatment for the same after ruling out active TB. 4. Children and adolescents 12 months to 15 years living with HIV should be given TB preventive therapy after ruling out TB. No contact is needed in the case of HIV positive children between 12 months and 15 years. Children living with human immunodeficiency virus less than 12 months should also be given TB preventive therapy if they are contact of a pulmonary TB. This also after ruling out TB. Next slide. Next slide. Children and adolescents less than 15 years plan to be initiated on anti-TNF treatments, receiving dialysis. TNF is anti-tumor necrosis factor treatment. Anti-tumor necrosis factor treatment. Receiving dialysis, preparing for an organ or hematological transplant, on immunosuppressive drugs for a longer duration, like more than 2 milligram per kilogram oral steroids for more than 2 weeks. Example, nephrotic syndrome, acute leukemia, systemic inflammatory conditions should be systematically tested for LTBI. If found to have LTBI, they shall be offered treatment for the same after ruling out active TB. No contact is needed in this case. That is very important. 7. Apart from these categories, children and adolescents less than 15 years on any chronic immunosuppressive conditions as decided by the pediatrician shall be tested and treated for LTBI. Next slide. For programmatic management and monitoring, children and adolescents less than 15 years who are household contacts of all microbiologically confirmed pulmonary TB patients notified after 1st November 2020 shall be considered as eligible. Those children and adolescents shall be enumerated during household contact tracing of all microbiologically confirmed pulmonary TB cases by the primary healthcare team. Next slide. Next slide, please. Testing for LTBI. LTBI testing is currently not a requirement for initiating TB preventive treatment for household contacts aged less than 5 years and children and adolescents living with HIV. For all other eligible children and adolescents, interferon gamma release assay, IGRA, shall be used for diagnosis of LTBI. Next slide. Now, we can discuss what is IGRA. IGRA and let us compare IGRA and tuberculin skin test. IGRA is an in vitro test and tuberculin skin test is an in vivo test. IGRA is done using well-identified antigens, whereas multiple uncharacterized, unquantified antigens are used for this MATO test, this tuberculin test. Actually, 2-TU PPD RT23 is required. It is not freely available. That is a problem with tuberculin skin test. No boosting occurs in case of IGRA. In case of tuberculin test, if it is done repeatedly, and in those who have taken BCG and all, that boosting effect occurs, and the reading may not be correct. IGRA is not affected by BCG. Tuberculin skin test may be affected. In case of IGRA, only one patient visit is required. IGRA is very costly compared to the tuberculin skin test, but it is more accurate and more predictable. In case of tuberculin skin test, 2 patient visits are required. There is minimal inter-reader variability in case of IGRA, because the reading is done using computer and all. In case of tuberculin skin test, significant inter-reader variability occurs. In case of IGRA, we will get the result in 1 day, but for tuberculin skin test, we have to ask the child to come after 2 to 3 days, between 48 to 72 hours. Standard TST not available. I have told you 2-TU PPD RT23 is what is required, but most of the times the standardized TST is not available. Next slide. Now we'll go to some details of IGRA. For collection, this green one is used. Next slide. Organizing the IGRA test. IGRA testing shall be set up at 46 public laboratories. There is 2 to 4 per district, according to the population and all. Some districts may need more, and some districts may need less. IGRA testing shall be set up at 46 public laboratories across the states. Apart from this, 16 private laboratories will also be performing IGRA tests. Dr. Arun has already stated that some hospitals in our district have been identified for this IGRA testing, some 5, I think. NTEP, National Tuberculosis Elimination Program, has established specimen collection and transportation systems for every peripheral health institution to transport samples in a hub and spoke model. From peripheral hospitals where IGRA laboratory is not co-located, blood samples for IGRA have to be collected in lithium heparin blood collection tubes and transported through the specimen collection and transportation system on prefixed days so as to reach the laboratory within 16 hours of collection if stored at room temperature, or within 48 hours if stored at 2 to 8 degrees Celsius. Laboratories will be performing IGRA only on specific days. These dates and times shall be disseminated. Now let us see what are these steps of the standard operating procedure of IGRA test. One is sample collection. The second is packing and shipping of samples. Third is sample qualification criteria. Transfer of blood to IGRA tubes in laboratory is the next step. Then incubation of tubes is the next step. Post-incubation and post-collection of plasma is the next step. Then ELISA test and calculations using computer, and then results. Next slide. These are the different steps in the SOP, standard operating procedure for IGRA. The stage 1 is blood incubation and harvesting. After blood collection, mix quantiferon TB gold tubes thoroughly by shaking or by turning tubes end over end. Then incubate tubes upright at 37 degrees Celsius for 16 to 24 hours. Then centrifuge the tubes at 1500 to 2200 RPM for 5 to 10 minutes. Harvest at least 200 microliter plasma from each tube. Store in racked microtubes or uncoated microplates. Add 50 microliter or of conjugate solution to each well. Add 50 microliter of plasma or standard. Shake covered plate for 1 minute. Incubate for 120 minutes of 120 minutes at room temperature. Then wash plates up to 6 times. Add 100 microliter tubertrates. Incubate 30 minutes at room temperature. Add 50 microliter of stop solution. Read.
Sir, we can skip this slide.
Yes, yes. This much details is not necessary. Okay, thank you. Thank you for the
Okay, sir, for that wonderful presentation. So there, the content sir presented very well, and we need to understand that when a contact is exposed to a source case, now 70% will not get the infection, only 30% will get the infection, and among that 30%, 90 to 95% go as persistent latent infection, and they are the late reactivation disease producers. So they need to be identified and treated for latent TB infection. So latent TB infection is a persistent inflammatory reaction going on in the body due to the mycobacterial antigens. And we need to identify the eligibility criteria. No? We used to treat children less than 5 years who are household contacts of microbiologically confirmed pulmonary TB. Previously, we need a smear positivity to treat these children, but nowadays it is not required. Microbiologically confirmed means either smear positive culture or nucleic acid antigen test CBNAT positivity, which are all included in microbiologically confirmed pulmonary TB. So less than 5 years, if they are having a contact, they need not be tested for LTBI. They can be directly given this TB preventive therapy. But we need to rule out active tuberculosis disease by analyzing the clinical features and taking chest X-ray and other things. You know, if there is an extra pulmonary like a lymph node is there, we need to investigate that also. And congenital tuberculosis, again, if a mother is diagnosed with tuberculosis in pregnancy, the baby should receive preventive therapy. But then here also we need to rule out congenital tuberculosis by appropriate measures. And these babies should be given BCG vaccination irrespective of the treatment given to that baby. Now, another age group has come in, which is children and adolescents 5 to 15 years of age who are also having contact. That means household contact. Household contact definition, sir has already told. That is a person who share the same living space with the patient for one or more nights or extended period of daytime. So that is a household contact. For 3 months before the start of the treatment to that person. So 3 months before he should have that contact. So that is household contact. Now, this 5 to 15 years age group is another group. If they are having a contact, they should be tested for LTBI. And testing for LTBI is IGRA test, interferon gamma release assay test, which is more specific than tuberculosis skin test, because it won't get interfered with, it won't get affected with BCG vaccination, and also non-tuberculous mycobacterium. If there is a non-tuberculous mycobacterium infection, that can be falsely positive. So that interference won't be there in IGRA, but a new skin test will come up next year or so, which is called CTB test. That also the same as IGRA, which is done in the same manner as tuberculosis skin test. And the reading is, taken as positive if it is more than 5 millimeter. In tuberculosis skin test, we take more than 10 millimeter as positive. And in CTB test, more than 5 millimeter is enough to say that it is positive. So that is the most important test which is going to come. If that is coming up, then we can avoid this IGRA test because it's very costly and it requires blood collection. Only problem is CTB test. It's also an intradermal test. It is read just like a TST test, tuberculous skin test. The problem is some hematoma formation is occurring more frequently than tuberculous skin test, but I don't think that's a big issue. So if it comes up, we can, take that test for identifying LTBI. So this 5 to 15 years, we need to rule out active tuberculosis and test for LTBI. And if found to have LTBI, they also should be given preventive therapy. Then children living with HIV, 1 to 15 years, they need not have a contact. They can be given tuberculosis preventive therapy. And children living with HIV less than 1 year, they should have a contact to start tuberculosis preventive therapy because there is an insufficient data on the benefit to these children if you start preventive therapy early. But these children should be followed up periodically for development of active tuberculosis. So this is the nutshell of sir's presentation. And I think any queries can be clarified. Any doubt about this latent tuberculosis eligibility criteria, testing for latent tuberculosis, and also the IGRA test? Okay. I think we can, if there are no problems here, no queries, we can move on to the next session. Any, or we can discuss it later also after finishing all the topic. Now the next topic is ruling out active tuberculosis, which is an important step for, before treating the child as LTBI. So for this, we have Dr. Shibu, and I invite Shibu for the presentation. Over to Shibu.
Respected seniors, friends and colleagues, hope I am audible. Faisal,
You're audible. You're audible.
Okay. As Joshi sir and Dr. Faisal nicely mentioned, we have to rule out active TB before initiating starting treatment for LTBI, as there is a very much remote possibility of drug resistance. So, active TB to be ruled out in any children or adolescents before initiating LTBI treatment. So, apart from history and clinical examination, we have to take chest X-ray to rule out active TB. If chest X-ray shows any abnormality, the child shall be further evaluated for TB according to the national guideline. So, chest X-ray can be normal. Chest X-ray can be suggestive of TB, or chest X-ray may be abnormal chest X-ray but not suggestive of TB. Clinical examination for lymph nodes and a thorough history for signs and symptoms of extrapulmonary tuberculosis shall be done. Clinical committee shall be constituted at district level. That should include a pediatrician from medical college, from health service, then pulmonology experts, and from district administration levels in regarding decision taking regarding doubtful cases. So the clinical presentation of the common forms of TB in a child. As you all know, the common symptoms are fever for 2 weeks or more, unremitting cough for 2 weeks or more, no weight gain despite adequate nutrition, or loss of more than 5% of body weight in past 3 months. Peripheral painless swelling, that is lymph node enlargement. Then meningitis of insidious onset. Then spine gibbous. Then any non-specific symptoms in the conduct of an infectious TB case. So this is the algorithm for pediatric intrathoracic TB among children with no risk factors for drug resistance. So the persistent fever more than 2 weeks without a known cause for fever, and unremitting cough for more than 2 weeks, and or there is weight loss of 5% or no weight gain in the past 3 months despite adequate nutrition, or failure of nutrition rehabilitation in a babies with a severe acute malnutrition. These are with or without contact with the patient with the pulmonary TB in the last 2 years. So we have to take a chest X-ray first. So the chest X-ray may be highly suggestive of pulmonary tuberculosis. We have to do other investigation like exaggerated sputum or gastric aspirate or induced sputum for National Tuberculosis Elimination Program approved rapid nucleic acid amplification test for Mycobacterium tuberculosis. If the NAT is positive, that is the nucleic acid amplification test is positive, it is microbiologically confirmed TB case. Then we have to look for rifampicin resistance. If rifampicin resistance is detected, reconfirm and follow drug resistant TB pathway. If no rifampicin resistance is detected, keep with the first line drug. And if the NAT is negative, look for any other sites like significantly enlarged peripheral enlarged lymph nodes and test the lymph node aspirate for Mycobacterium tuberculosis. Consider repeat nucleic acid amplification test for better quality specimen or alternative specimen like bronchoalveolar lavage or aspirate depending upon the availability and feasibility. Then may seek review from higher center. And again, the NAT is positive. We have to go back like it is confirmed as microbiologically confirmed TB case. And if the NAT is negative or the repeat test is not indicated or feasible, if there is no other likely alternative diagnosis, treat as clinically diagnosed probable TB case. And If the chest X-ray is shows non-specific shadows, give course of appropriate antibiotic. If child is already on antibiotic, give a full course of antibiotic. Then again look for shadows after some time, some days. If there is persistence of shadow and symptoms, you have to go back, like, do a nucleic acid amplification test and follow the algorithm. If the chest X-ray is normal, we have to evaluate for extrapulmonary tuberculosis. Consider referral to higher center for detailed investigation and for a alternate cause. Which is the algorithm for? Then in chest X-ray, lymphadenopathy, we all know direct signs, that is hilar lymphadenopathy, that is sharply demarcated and lobulated density or ill-defined with the vague borders occupying the hilum and obliterating the hilar points. That is the hilar lymphadenopathy. Then indirect signs like condor and caliber of trachea may be obliterated due to compression of hilar lymph nodes, and there is the splaying of carina can be seen due to compression of hilar lymph nodes. These are the some X-rays. That is, in first there is hilar lymph nodes. Second is there is miliary tuberculosis. Then fibrocavitary lesions. Then primary TB with hilar lymph nodes. Then hilar lymph nodes with associated length. There is primary complex. Then there is progressive primary TB. This X-ray shows cavity in a consolidation. In right side, there is right-sided cavity in a consolidation. And fibrocavitary lesion on the right and left lung. Then about extrapulmonary tuberculosis, our aim to get microbiological diagnosis, that is the lymph node. In cervical lymph nodes, the Mando positivity up to 70%. Then we have to do FNAC, CBNAT, AFB smear, the MGIT is mycobacterial growth indicator tube. Then excision biopsy for confirming the mycobacteria. Then about pleural, we have to do CBNAT sputum, gastric aspirate, then pleural fluid, pleural tissue biopsy, it's definitive. And about the pleural fluid, clinical symptoms with this exudative fluid that more than lymphocytic, more than 50%, protein more than 3 gram %, straw colored, Mando will be positive. Patient may be sick or may not be sick. There will be long history. About abdominal, this intestinal, nodal, peritoneal, visceral, we have to do in X-ray, ultrasound, barium studies, contrast enhanced CT angiography. Then about CNS tuberculosis, tuberculous meningitis, infarcts in the basal ganglia, hydrocephalus tuberculoma. In that case, CSF will be clear, 10 to 100 lymphocyte, low glucose, high protein. You should be sent for CBNAT. Tuberculosis sensitivity should be positive in 50%, up to 50% case. We have to do chest X-ray, look for any lymph node enlargement, then contrast enhanced CT, contrast MRI. About bone and joint tuberculosis, spots, dactylitis, osteomyelitis, arthritis, reactive arthritis, bursitis. X-ray spine shows 30 to 50% loss of bone tissue, and MRI will be 100% sensitive. So this is the algorithm for active tuberculosis disease that looks for signs and symptoms of TB. That is cough, hemoptysis, fever, night sweats, weight loss or poor weight gain, chest pain, shortness of breath, fatigue, and the child is not eating well. These symptoms are present. Investigate for active TB disease as per National Tuberculosis Elimination Pediatric Guidelines. If active TB disease is present, treat for active TB. If active TB is ruled out, test for LTBI, and if positive, consider treatment for LTBI. And the symptoms are absent, do IGRA. If IGRA is positive, do chest X-ray, and chest X-ray show any abnormality, then we have to do again investigate for active TB disease as per NTB pediatric guidelines, and chest X-ray shows no abnormality. Then clinical examination for lymph nodes and history and signs and symptoms of extrapulmonary tuberculosis. And if it is present, back to rule out active TB disease, and it is absent, assess contraindication, do baseline assessments, and decide on treating latent TB infection. So this is about active to rule out active TB disease.
Okay, Shibu, for that nice presentation. The idea is very clear. So if there is a child who is having household contact with microbiologically confirmed tuberculosis, we need to rule out active tuberculosis by clinical examination, history and examination. If there are no clue in history and examination, the child is okay, then we have to go for IGRA test. And if it is positive, then we have to take a chest X-ray. And if chest X-ray is normal, then again we search for extrapulmonary tuberculosis clinical features. If that is absent, then only we give this latent tuberculosis treatment. In anywhere we find that this child is a probable candidate for active TB, we have to investigate for active. And see, I got disconnected for some time. So I found one question in chat box about the previous talk. It was like this: 11-month-old baby, got tuberculosis preventive treatment because grandfather was positive, but grandfather was continues to be sputum positive after 6 months. And the child is also not gaining weight. That child should be tested for active TB, and because the child satisfy the criteria for presumptive TB, because the child is not gaining weight, the baby is not gaining weight, or is declining, his growth is declining. In that case, we need to rule out active TB by appropriate test. And also we should test for the drug-resistant tuberculosis in that grandfather also. So these two things should be there. Because in my chat box it is empty because I got disconnected totally for 5 minutes. So any other questions you can put in a chat box, or you can ask, because I can't find any other questions in the chat box. So this was a question I read before this talk. So, but he is not tested means he should be tested. So that is a new guideline, because we should follow these new guidelines. And also we should notify, because it's become a notifiable disease. Failure to notify this TB, we are liable to get action against us. So that is an important thing we need to understand here. So regarding this talk by Dr. Shibu, any clarification we can put in the chat box or ask directly. Otherwise, we can go to the next talk, which is by Dr. Juman. I invite Dr. Juman.
Thank you, Dr. Faisal. I think I am audible. Am I audible?
Yeah, you are audible. Go on.
Shibu sir, could you please continue with the slide sharing for me also? Shibu sir? Dr. Shibu? Shibu sir, പോയോ?
വരുന്നുണ്ട്.
Okay, thank you. And then in continue. Okay. So good evening, respected teachers, senior leaders, and dear friends.
Teachers, senior leaders, and dear friends. Teachers, senior leaders, and dear friends.
I think there is some disturbance.
Audio
Some disturbance is there.
I don't know whether it is mine or some other problem. I
Now
think
it is-
Now it's okay. Juman.
You are audible.
Okay. For time being, I am avoiding my video and continue with audio only. And
Okay.
screen. I mean, slides are there.
Okay.
So,
Broadband problem.
okay, so let us continue. So now in the previous sessions, already we discussed in detail about the importance of LTBI testing and treatment. We understood about the eligibility criteria, and we also discussed in detail about how to roll out an active TB disease in a child. So now we have a child who is eligible for LTBI treatment, and we already rolled out the active TB in that child. So now we have to treat the child for latent TB infection. So we have 4 options available. One is the treatment with the INH alone for 6 months. And another option is 3 months of combination therapy with the INH and rifampicin. Then 4 months of rifampicin is another option. And weekly rifampicin with INH in more than 2 years old child. These are the 4 options available for the treatment of latent TB infection. So in our state, next slide please. So in our state, we prefer to treat these children with 3 months course of daily dose of isoniazid plus rifampicin. So all eligible children and adolescents in the age group below 15 years who were diagnosed to have LTBI should be provided treatment with a 3 months daily dose of isoniazid plus rifampicin, of course after rolling out active TB disease. Next. So why we prefer this 3 HR regimen? Because the risk of adverse effects of this regimen is very much lower as compared to longer duration of INH alone regimen. And also, as the duration of treatment is shorter, the chance of adherence is more. And this HR regimen is very much familiar to the practicing pediatricians and child-friendly fixed dose combinations are freely available. And also in our state, the risk of, the drug resistance to rifampicin is much lower. And we have a very adequate system to roll out active TB infection. So because of these reasons, we prefer to use 3 HR regimen for the treatment of LTBI infection. And next slide. Yes. And this regimen is evidence-based also. The studies shows that safety profile and efficacy of this regimen is similar to that of the 6 months INH treatment. And also studies reported that no clinical disease in both the groups, that is the new radiographic findings suggestive of active TB is not reported, and fewer participants given daily HR regimen developed radiographic changes as compared to the 9 months INH therapy. And also these studies showed lower risk of adverse events and higher adherence rate. And because of these reasons, we decided to go with 3 HR regimen. Next. So to treat with HR regimen for these children, the dose of drugs is in a child who is 10 years or older child, the dose of isoniazid is 5 milligram per kilogram per day, and dose of rifampicin is 10 milligram per kilogram per day. In younger children, in children who are less than 10 years old, the dose is, isoniazid dose is 10 milligram per kilogram per day, and rifampicin dose is 15 milligram per kilogram per day. Next. So we are using the fixed drug combination FDCs. FDC available in a dose of rifampicin of 75 milligram and isoniazid of 50 milligram. We are using 4 weight bands. In 4 to 7 kilogram group, we have to give 1 tablet daily. In 8 to 11 kilogram group, we have to give 2 tablets. 12 to 15 kilogram weight band, we have to give 3 tablets. And 16 to 24 kilogram weight band, we have to give 4 tablets daily for 3 months. If the child is more than 25 kilogram body weight, we have to use adult formulations. Next. Now, the next important point is the pyridoxine supplementation. Pyridoxine supplementation is very much important because the risk of peripheral neuropathy is much more, and it is often undetected in young children. So we have to supplement pyridoxine in all children who are receiving an INH containing preparation for more than 3 months. And also we have to supplement with pyridoxine in children with increased risk, that is the children, malnourished children, children living with HIV infection, children with renal failure, and those children with diabetes. In such children also we have to supplement pyridoxine if they are receiving an INH containing preparation. And also in infants, exclusively breastfed infants should also receive pyridoxine supplementation if they are receiving INH containing preparations. And the dose of pyridoxine supplementation is 10 to 25 milligram daily. Next. Now, what are the contraindications for TB preventive therapy? That's our treatment. The first and most important contraindication of TB preventive therapy is history of contact of any drug-resistant TB. If the child is a contact of a drug-resistant TB, we should not treat that child with our HR regimen. Instead of that, we have to refer that child to a district pediatric clinical committee, which I already mentioned during the previous sessions. We have to refer to that committee, and that committee will assess, evaluate the child, and will give individualized preventive treatment according to the drug sensitivity profile of the index case. So we should not treat with our HR regimen. For such children, we should not give treatment. And the other contraindications are the active hepatitis, whether it is acute or chronic active hepatitis, and also symptoms of peripheral neuropathy. So in such conditions, if the child is having hepatitis or symptoms of peripheral neuropathy, we have to do detailed evaluation, and we have to apply our clinical judgment to weigh harms versus benefits of the treatment of LTBI, and we have to decide accordingly. Next slide. So the next session is about the baseline assessment and counseling of those children and their parents. So in the baseline assessment, we have, of course, we have to take a detailed history, especially regarding the history of any drug allergy and any other medications. And also we should specifically ask for or specifically look for the contact with the drug-resistant TB with the reason we have already mentioned. Then we have to look for the other potential contraindications to the drugs. We have to assess the comorbidities, malnutrition, HIV infection, renal failure, and diabetes. We have to assess, and we have to assess the social and financial situation of the family. And if needed, we have to arrange essential support, for which we can use the help of concerned primary health care system. And also the patient may need a treatment supporter. If a treatment supporter outside the family is needed, we have to arrange such a supporter concerned and a baseline liver enzyme testing should be done
Please mute, Jalil.
Next slide, please.
Dr. Jalil, please mute.
And we have to give counseling to the parents of these children. We have to make them aware of the rationale for this management and benefit of the treatment, both for the all the benefits to the individual, to the household, and to the community. And we should make them aware that this management is available free of cost through the national programs. And we have to counsel them regarding the prescribed regimen, duration, directions of for intake of medicines, and follow-up schedules. And we should educate them regarding potential side effects and if what to do if such a side effect occurs. Then we have to stress on the importance of completing the full course of treatment and the importance of clinical and laboratory follow-up and treatment monitoring. And we have to educate them regarding the signs and symptoms of TB, and we have to advise on the steps if they develop any of such symptoms. So, honestly, I think this is the end of this session. So the remaining session will be taken by
thank you.
Person.
Thank you.
So,
thank you, Dr. Juman. The message is very clear. We are going to, give 3 HR. That means 3 months daily rifampicin and INH for preventive therapy. Because previously we were giving INH for 6 months. So we are going to start this type of, this regimen very soon. And there are a few questions here. The follow-up question of the last one, that why that child was not tested because they sent to TB clinic and not doing anything. I think as a pediatrician, we should know that not gaining weight for 3 months or 5% loss from the maximum weight in the last 3 months also a criteria to test for active tuberculosis. So we need to test. We have to take the initiative here, and then because there is a system of TB testing in a private sector also, that is called STEPS. So that in that we can also do this testing and diagnose active tuberculosis in this side. There is no problem. And another question, again a follow-up question of that. Why the child was given only INH? Because that was a practice, and we are going to implement this from November onwards because there are a lot of logistic and technical issues, and also the COVID situation. It has not come into existence and not commonly practiced, and we are going to practice this going forward. So we are going to give 3 HR for these children, and dose, as Juman mentioned, about 10 years, less than 10 years is different for INH and rifampicin. And another question is for the daytime household contact, what is the minimum time required? They are not mentioning about minimum time. The 1 night is enough for the nighttime contact. But daytime contact, frequent daytime contact only they are given. So you can assess clinically if the child is required to, to be tested for LTBI, we can go for that. Frequent daytime contact. Frequent means a few days. That's what I understand about that statement. So that's about the questions in the chat box. And I think we can move on to the next session, which is adverse event monitoring and ensuring treatment adherence about this LTBI. And for that, I invite Dr. Shibu, Dr. Debu.
Respected senior doctors and my dear friends, good evening. Hope I am audible to you all.
Yes. Yeah, audible. Go on.
First, let me thank IAP Malappuram for giving me this opportunity. I will be dealing with adverse events monitoring, ensuring treatment adherence first. Dr. Shibu, can you pass the slide? Okay. Adherence to LTBI therapy is of paramount importance and completion of the...
Deepu, 1 second. I think if there are any questions, you can put up in that chat box or you can directly ask after the session. Okay, thank you. Deepu.
Okay. Adherence to LTBI therapy is of paramount importance and completion of the entire course lead to clinical benefit both at individual and population levels. Irregular or inadequate treatment reduces the protective efficacy of LTBI regime and further increase the risk of individual developing active TB disease, including drug-resistant TB. Effective LTBI management is greatest if at least 80% of the doses are taken within the duration of regimen. 80% doses means that 3 months HR is given. Of that, there are 84 doses. Of 84 doses, if the child is taking 68 doses, it is 80% of the dose. That is adequate for completion of treatment. Total number of doses taken is the key determinant of the extent of TB prevention. Children on LTBI regime shall be followed up through primary healthcare system in public sector or through system for tuberculosis elimination program in private sector, that is STEPS model in private sector. Treatment shall be under supervision. A treatment supporter, that is a family treatment supporter, has to be decided from the family is preferred. If family is identified to require external support on assessment, a treatment supporter from the community shall be arranged. It can be anyone from the community who is able to monitor the treatment. Treatment supporter shall look for adverse events and monitor adherence of treatment daily. Primary healthcare team assesses the need for family. The family may be linked to treatment support groups by primary healthcare team if the family requires any assistance or support for completing the treatment. So there should be treatment supported and primary healthcare team assesses the requirement for the family. Next slide, please. The treatment supporter need to mark tick against each dose in the LTBI treatment card. The LTBI treatment card shall be reviewed every week by the primary healthcare team and update the information in LTBI application. Retrieval action shall be taken by the primary healthcare team if treatment interruption occurs. You have to find out the cause for interruption and retrieval action should be taken. Next slide, please. Child or adolescent on LTBI treatment shall be seen by a medical officer at least once in a month and look for the following. The signs and symptoms of TB disease, adverse reactions, especially symptoms and signs of hepatitis, adherence to the prescribed regimen, elicit reasons for any missed dose, and extend necessary support to enable future adherence to the LTBI management. All this has to be seen by the medical officer of the primary health center. Next slide, please. Any adverse drug reactions shall be recorded in the treatment card. Adverse events also need to be reported through Pharmacovigilance Program of India. Family where children on LTBI management need to contact healthcare worker or provider or treatment supporter if they notice adverse events such as anorexia, nausea, vomiting, abdominal discomfort, persistent fatigue or weakness, dark colored urine, pale stools or jaundice. These are suggestive of liver injury and require urgent evaluation under the medical officer. Relevant investigations need to be done as clinically indicated. So always the treatment supporter should have a look about on the adverse events and have to be updated properly. Next is monitoring indicators, treatment outcome, long-term follow-up and flow of events. Monitoring indicators, this includes the total eligible children and adolescents, that is 5 to 15 years identified. Of the eligible children identified, percentage tested for LTBI infection, and out of the percentage tested, proportion diagnosed to have LTBI, and of the proportion eligible for TB preventive of that see previously the proportion eligible for TB preventive treatment, and among the proportion eligible for TB preventive treatment, proportion initiated on treatment, and of the proportion initiated on treatment, proportion completed the course. All these are the has to be monitored, and these are the monitoring indicators. Next slide. these definitions, these are the treatment outcomes, and all these definitions has to be known. Treatment completion, that is a child or adolescent initiated on LTBA management who completed at least 80% of the recommended dose, that is 68 of 84 doses consumed within 120% of the planned LTBA management. That is 100 days of 3HR is planned. That is a 120% of that 84. There will be 84 doses and minimum 68 doses should be consumed. Treatment failed means a person initiated on LTBA management who developed TB disease anytime while on LTBA management. Died. A person initiated on LTBA management who died for any reason while on LTBA management. Lost follow-up. LTBA management is interrupted by a person for 4 consecutive weeks for 3HR. LTBA management discontinuation due to toxicity. A person whose LTBA management is discontinued by clinician due to adverse events or drug-drug interactions without treatment completion. Not evaluated. Cases such as in cases which includes records lost, transfer to another healthcare facility without records of LTBA management completion. All these includes under not evaluated. Long-term follow-up. All children and adolescents who are household contacts of pulmonary TB shall be followed up every quarter by the primary healthcare team looking for development of active tuberculosis, symptoms and signs of active TB. The same vigil shall continue for all children and adolescents who were diagnosed with LTBA even after those who complete the treatment. If any child initiated on LTBA later developed TB, tests for detecting resistance to INH and rifampicin shall be offered at the baseline if biological specimen is available. So always these children has to be continuously monitored for development of tuberculosis. And if there is a development of tuberculosis, INH and rifampicin resistance has to be tested as they are already on INH and rifampicin. Evidence generation. Prevalence of LTBA among children and adolescents, we have to create evidence for all these things. That is, who are household contacts of pulmonary TB. The second is clinically vulnerable group. And adverse events among children receiving LTBA treatment. Facilitators and challenges during the entire process. Follow up of all these children for 5 years and study the development of active TB and drug resistance. All this has to be done properly, then only we can generate an evidence how much of the percentage are developing tuberculosis even after treatment, or who are all the eligible contacts of among the percentage of eligible contacts developing TB, all those things. And this is the flow of events. First is identification of eligible children, contact tracing. Next is testing for LTBI, rule out active TB, and baseline assessment and initiation of LTBA treatment, and monitoring for adverse events and ensuring treatment adherence. Monthly clinical follow-up with medical officer, declaring treatment outcome, and long-term follow-up. These are the flow of events in LTBA management. This is recording and reporting. If the child or adolescent is diagnosed to have LTBA, clearly document it as LTBA in all the medical records for all eligible children. Information management on LTBA shall be in separate LTBA application linked to the NISHAI, the current TB management information system. Provisions for recording and tracing, recording of tracing and testing household contacts shall be there at treatment card for every TB patient. There shall be 2 physical LTBA record for every child and adolescent tested positive for LTBA. One need to be kept with the treatment supporter and the second one at the treating facility. The card at the treatment facility shall be updated monthly after following up the child or adolescents. During the monthly visit, the card at the treatment facility has to be updated with the card with the treatment supporter. Next. On declaration of outcomes, the LTBA treatment card shall be collected and maintained at the tuberculosis unit by the senior treatment supervisor, that is STS. If any child or adolescent has interrupted the treatment, retrieval actions shall be taken and documented by the local primary healthcare team or STS. PHC medical officer where the child resides compiles the quarterly report with the help of senior treatment supervisor. Consolidation happens through the routine NTEP mechanisms. So run-in period is the service delivery will be starting, as mentioned, to be started from November 15, 2020, that is 3 months back. However, since it is a new program, logistics challenges are expected. There might be delay in supply of FDC combinations for children weighing more than 25 kg, public laboratories performing IGRA for the first time, and specimen collection and transport system need to be customized for blood sample collections, as it has to be reached at the testing center within 16 hours, or if there is a delay, it has to be refrigerated at 2 to 8 degrees Celsius for 48 hours. So it may take few days for streamline services. As COVID is pandemic at its peak, the delays are expected. First 2 months shall be considered as a run-in period to streamline the entire process. The tuberculosis working group shall meet after 1 month of implementation and suggest mid-course corrections, if any. Next slide. District Pediatric TB Committee. A district level pediatric TB clinical expert committee shall be constituted with 5 members in each district. The committee shall consist of pediatricians from medical college, health service, and private sector. State IAP shall nominate members for its committee in every district. District medical officer of the concerned district shall finalize the list and issue orders. Chair or vice chair of the committee shall be nominated. Consultant pulmonologist as district TB center shall be the convener for the committee. Role of the committee is to help clinicians to arrive final decision in any clinical dilemma related to pediatric TB or LTBI management, to make decision on initiating individualized preventive treatment for contacts of resistant TB, to oversee practices regarding TB management in district through peer audit system and give recommendations for improving the standard of care, to oversee and suggest recommendations to district authorities related to program implementation for ensuring that every child receives TB services as envisioned. Frequency of meeting tuberculosis committee. Meetings should be in online platform. The current scenario at frequency of once a month or as and when required. At least 3 members are required for a quorum. So there should be at least 3 members during each meeting. Then only it is a valid meeting. During the meeting process, any queries related to the decision making shall be referred to the committee by any modern medicine doctors, formally to chair or convener with detailed and sufficient clinical records. Committee shall give their clinical opinion in a documented manner. Apart from this, committee will do peer audit of at least 2 pediatric TB or LTBA cases in every sitting based on the right diagnosis, right drugs, right dose, right duration, and right frequency in comparison to the standard set by IAP National Tuberculosis Elimination Program, and give feedback to the treating clinician. The entire exercise is purely a measure for quality and standard improvement. The committee shall give feedback to district authorities periodically regarding the measures to be taken to improve the program in the district. So if there is any query or confusion regarding tuberculosis, any physician or modern medicine doctor can send proper details to the committee, and it will be discussed in the next committee meeting, and monthly meeting will be there. Then minimum 3 persons should be there for a quorum to have this meeting. Next slide. That's all. Thank you.
Thank you, Deepu, for that excellent presentation. And see here, the most important thing is monitoring. If you are starting preventive therapy, LTBI treatment for a child, we should monitor regularly for the development of active tuberculosis. So the first question was asked, regarding that question, I think the answer lies in this presentation also, because if you had monitored that child, loss of weight or not gaining weight, it's also an indication that the child might have by appropriate test and treat accordingly. So we should monitor all these children regularly for the development of active. And also, if the child on INH and rifampicin therapy develops the disease, we need to check the resistance also. So that is another message which is conveyed here. And one more question in the chat box is there any role for Mando test hereafter after IGRA? See, IGRA is to diagnose a latent tuberculosis infection only. And Mando test has got a very limited role nowadays. And the role is if somebody suspect active tuberculosis by the symptomatology like unremitting cough, persistent fever, loss of weight, or poor weight gain, all these things, we should take a chest X-ray. If chest X-ray is suggestive of tuberculosis, that means if it contains, if it shows hilar adenopathy or metastasis, like CB-NAT and TrueNAT. If that is positive, we can take it as microbiologically confirmed tuberculosis. If that is negative, now we need to take another sample if possible by gastric aspirate to induce sputum and recheck it again. If again it is negative, we are again suspecting strongly that this child is having tuberculosis because of the type of chest X-ray lesion. We can go for Mando, and if Mando is positive, we can diagnose at clinically diagnosed tuberculosis if there are no alternative diagnosis available. So there, Mando has a little role going forward. Otherwise, it has got only minimal role in this type of, in the new NTEP program. When do you expect the system to be functional? I think I don't know exactly, but we hopefully this year, within 2-3 months, it will be operational fully. And the district TB officer here,
yes,
Dr.
sir.
Arun.
Sir, I will say, sir.
Yeah.
Sir, actually, all the labs are equipped now with the equipments. Now, the last round of training for the lab technicians will be conducted by next week. So in 3 weeks, we can start the program.
Okay, that's wonderful. I think within a month we'll be starting this program. And,
yes, sir.
Yeah. Thank you for that information. Any other queries? I think you can put up in the chat box or can ask also directly. So these are the chat box questions. So it's very important to know that this is a notifiable disease and we need to notify it, and the treatment should be organized and uniform. So that is very important. So we can't just give ITT, just write Mando positivity, lymphocytosis, ESR elevation. That's not going to work anymore. I think we need to be more scientific and evaluate extensively and find out microbiological proof for tuberculosis most of the time. Anything else, sir? Joshi sir?
I think there are no more questions in the chat box. If anybody has any doubts regarding the implementation of the program and all, they can ask. DTO is there. And another question about this Mando test. Till IGRA, when IGRA is not available, knowing about the limitations of Mando, we can do Mando till IGRA test is made available. Actually, CTB skin test is the best test, but it is not at present available. When CTB skin test becomes available, this costly IGRA test will go from the picture. That is what I think. If 2TU PPD RT23 for Mando test is available, still we can do Mando test till IGRA is made available. Even otherwise, if IGRA is not available, I think we can use Mando test.
but I think it will become available very soon, as DTO mentioned about it. Within a month, it will be functional. And Mando test, we can use the standard is, as you rightly mentioned, 2 TU, RTT23. That is not available, but we can use the other one, the 5 TU PPDS, the standard PPD 5, which is commonly used nowadays.
If there are no more questions, I think we will conclude the session. Dr. Ashraf sir has not joined, isn't it?
Yes, not joined.
No. Yes, not joined.
Okay. So thank you everyone for your patient listening, and I hand over the proceedings to Dr. Akbar Sadiq.
Now I invite Dr. Juman to give a proposal.
For vote of thanks.
Dr. Juman.
Hello, good evening once again to all. Now it is time is already too late, and I think it's a very informative and wonderful session. And as a practicing pediatrician, and as the RNDCP program is changing to NTP, National TB Elimination Program, this information is very important, and I think this session is, time is already late. I am going directly to my responsibility for the sake of formal sincere to all those participated in this session, especially our leaders, Jayaraman sir, Narayan sir, Balendra sir, Joshi sir, our WHO consultant Dr. Dagesh sir, DTO Dr. Arun sir.
I think there is net problem. We will conclude the session. Juman internet problem.
Hello. അല്ല അതിന്റെ ഇടക്കൊന്ന് കട്ട് ആയെന്ന് തോന്നുന്നു. ഐ തിങ്ക് ഞാൻ പറഞ്ഞ ഫുള്ള് കേട്ടില്ലേ? ഓക്കെ, എന്തായാലും എല്ലാവർക്കും പിന്നെ നന്ദി പ്രകാശിപ്പിച്ചു. അതിന്റെ ഇടക്ക് എന്തോന്ന് കട്ടായി പോയി. ഓക്കെ, താങ്ക് യു.
Okay, meeting being right away. Thank you.
Thank you.
Thank you. Good night.
Good night.
Good night all.